Liana, Liana to give us a welcome. So, Liana.
Good morning, everybody. Thank you so much for joining us today. As many of you probably know, we have been doing these webinars, gosh, for over a year now, which seems rather unbelievable, and really began to do them in response to what was early disparities in the effects of COVID-19 on racial and ethnic minority communities. And really began to do these as a way for clinicians, as a way for providers to come together and really discuss best practices in trying to reduce those disparities. And so we've had a number of guests with us over the last year that have really helped us to look a little bit more deeply at the impacts of health disparities in various communities in Maine and think about how to partner with community-based organizations in order to really move the needle on some of these issues. We're really thrilled today that Yaffe is here with us for just by way of background a little bit. We headed into a pandemic without an Office of Population Health Equity. We were one of the few states in the nation that didn't have one anymore within our CDC. And it really became quite apparent the need for that level of intentionality when it comes to health equity work at the department. And so we are really thrilled to bring that back. It has historically existed. It was once called the Office of Minority Health, later the Office of Health Equity, but had waned in the last administration. And so while it took some time, we were really happy to be able to reestablish that office under Ian's leadership. Ian comes to us, well, technically he was already with the department, but for a short period of time, he was managing many of the contracts that we had for social services and vaccine equity with community-based organizations. So was really familiar with some of the work that we've been doing over the last year to better partner with communities. But prior to that, actually was the executive director of one of those organizations with whom the state has worked very closely on COVID response, Mano and Mano. And I'll let Ian tell a little bit more about that work and what brings him to the state. But we are thrilled to have him. He brings a community perspective and he brings in a tremendous amount of knowledge and a lot of respect in the field. And so we are really thrilled to have him as a partner in this work and look forward to seeing that office really flourish and develop. So with that, Ian, I'll turn it over to you.
Sure. Well, thanks very much. Good morning. As Liana mentioned, my name is Ian, and I am the new Director of the Office of Population Health Equity at Maine CDC. Excited to talk to you a little bit about what our priorities are this upcoming next couple years, and also share a little bit of information that we put together about where the COVID-19 disparities are in Maine right now. So I'm gonna maybe start with those because I think it helps illuminate, it's the most relevant topic here. It helps illuminate some of the thinking that goes into the Office of Population Health Equity. And while the Office of Population Health Equity is certainly not going to be a COVID response office exclusively, the way that the pandemic has shaped our public health response is certainly related to the future strategies of how to prevent these disparities from continuing to happen in the future. So I will pull up my screen here. And so the first thing that I wanted to show was just a line graph of, press the button, right? So the first thing I wanted to show was a line graph of the percent of total COVID-19 cases by race and ethnicity in Maine. And I show this slide mostly because it's confusing. And that's one of the downfalls of the information that we've seen during the pandemic is there's so much information out there. Every day you get new information about where the pandemic is at, and it can make it hard to figure out what disparities actually look like on an ongoing basis. I do want to point, you'll see a couple of obvious things here. One is that in the spring of 2020, at the beginning of the pandemic, you can see a very noticeable decrease in the number of cases among white people in Maine, and a very obvious increase in the number of cases among Black and African American people in Maine. And so that is something that I'm guessing you've already heard and already talked about. At one point in time, Maine had one of the worst disparities among Black and African Americans in terms of case rates. And a lot has changed since then.
I'm sorry, just because my old eyes have a hard time seeing it. I was just using my pointer to show the line, but I'm not sure if my pointer's showing up because you're screen sharing. Oh, so you might just want to, there you go. Thank you.
Can you see the?
Yeah,
awesome.
and just
Thank
maybe
you.
explain the key because it's a little bit hard to see for folks, so the gray being black. Sorry.
Yeah, so the blue line up here is the, that is the percentage of cases among people who identify as white. The dotted line at the top is among people who identify as not being Hispanic or Latino. And so we do have some challenges with the way that data are collected based on OMB standards that just mean that we have to treat race and ethnicity separately, but it gets messy to try and look at them at the same time. And so this line, the gray line here, this is the case rate among African American and Black people in Maine. The bottom lines represent Hispanic or Latino, 2 or more races, multiracial, Native Hawaiian or Pacific Islander, and American Indian or Alaskan Native. And so I am going to go to the next slide because this is mostly just to show that it's messy. And so I didn't want to spend too much time demonstrating that data are messy. I do also want to demonstrate one thing though, over here on the right side. This is typically what a lot of data looks like when you look at health disparities data in Maine, is you look at it and you're like, well, there's some group of folks that are a smaller percentage of the population. And it's like, you can't really tell, is that a disparity or not a disparity? There's not a lot of people of color in Maine. Is this good or bad? You wouldn't necessarily know. So what we did was we tried to, in the next slide, really try to think about a different way to present those data. And so now you just have 2 lines. The blue line is the percent of COVID-19 cases among people of color in Maine. And the orange line represents the percentage that those people are of Maine's population. And so here you can see a very clear and an even more stark example of what the case rate discrepancy disparity looked like. So just highlighting again, what looked like was pretty concerning before, but it, maybe it's hard to tell because there's so much other information. You can see that at June 2020, almost half of all of the cases in Maine were among people of color. And that in June 2020, as well as today, those groups of people are about 10% of our population. I will point that a lot of times when we hear conversations about race and ethnicity, the first thing that comes up is that Maine is one of the whitest states in the nation, and that is true. That also does not mean that there are not a significant number of people of color here, historically, as well as today, and that is the fastest growing population group in the state of Maine. And so what was a closer to 5% share of the population in the last census is now closer to a 10% share. And there's lots of reasons demographically why the shift is occurring, but just want to point that out that even in a state as small as Maine and in a percentage of people around 10%, we're still talking about 100,000+ people. This is not a small community. It's not the same as a small town in Maine. So I just wanted to point out these data just to show that what we saw here is that people of color feel the impact of pandemics, natural disasters, and other emergencies sooner and in greater numbers proportional to the population. I'm guessing that you all are aware, but there are no genetic or biological reasons for this. These are all social and constructed reasons. So these disparities are a choice. They're not something that's set in stone by biology. This isn't new information. It's certainly not new information to many of our partners who, right here at the beginning of the pandemic, they knew where this line was going before we had data to show the outcomes. And so there are a lot of reasons why people of color have seen in these case rate disparities. Those include additional exposure and increased exposure due to occupations, due to the housing that folks live in, multi-generational housing, congregate housing, and there's a lot of risk factors for COVID that are amplified among people of color in Maine. There are also additional burdens that this all means. And so even if we're just talking about case rates, which means isolation and quarantine, we're talking about communities that are less likely to have access to culturally and linguistically appropriate resources and care, less likely to have access to insurance and regular medical care, less likely to have access to sick leave to prevent the financial impact of having to be in isolation, and are more likely to expose family members and relatives who aren't able to find another place to be during isolation and quarantine. So I just want to point that out before we move into some of the other slides, that not only is this a big disparity, but the people who it affects have some of the least ability to respond to that disparity. And that does not mean that we believe that communities that doesn't mean that people aren't strong and that they don't have support. It means that communities have to rely on each other to a much larger extent than with other people who have experienced COVID during this pandemic in Maine. The next slide looks at the same data among ethnicity now. So this is looking at the data among people who identified as Hispanic or Latino compared to the state population. And so I'm just going to go back to the other slide really quickly and then over here. And you can see that there's a pretty similar trend at the beginning of the pandemic. And then this summer, we've seen an increase in cases among these communities. This could be due to there being additional community members here. It could be with seasonal workers, and it could be due to additional spread of the pandemic, especially in rural communities. The hospitalization data looked very similar to the case data, so I didn't add a slide for it, but we do have those data available. But for the interest of time, I just wanted to focus here on the things that look different. So again, before what I want to show now, this is looking at the information that we have about COVID-19 related deaths among people of color in Maine. I'm going to go back to the case data, and you can see that this is different. And so you can see that at the very beginning of the pandemic, when there was such a huge disparity of cases, that there was not a corresponding disparity in deaths. And that is both related to the reasons why communities were exposed at the beginning. And so generally at that time in the pandemic, you were talking about younger, healthier people who were able to recover from COVID versus the initial wave, and how that had a much different effect among people in nursing homes and other communities that were at a much higher risk of death from COVID. We do see a difference in death rates though in the fall, where we saw a much higher disparity in deaths that was not related to a corresponding disparity in cases. And so all of this information is just to share with you that it's really hard to know what's going on, and it's hard to know what the data mean. And for us, what that means is that it's really important to be in relationship with communities and with directly impacted communities and leaders who are accountable to those communities, who are able to articulate this information before it shows up on a chart and are able to articulate the strategies that are going to be most successful at protecting those communities. One piece I want to continue here, and then I'm going to take down the slides and we can have a little bit more of a conversation, is the percentage of cases and hospitalizations that are missing data on race or ethnicity. I didn't include the percentage of cases of deaths that are missing data on race and ethnicity because that's almost none. But we do see a pretty wide variation in the data that are collected around race and ethnicity that can make it harder for us to spot disparities. And so you can see at the very beginning of the pandemic, as cases begin to rise, we also saw hospitalizations rising with missing ethnicity and racial data. And there was a pretty concerted effort among our partners and among DHHS leadership at that time to stress the importance of collecting that information and reporting it regularly. And we saw very marked improvement in that information collecting by the time that we got to May. So looking here, you can see that the trend lines decreased. This is still a significant amount, but they decreased. Over time, what we saw is that as the pandemic response grew, particularly among case data, we saw that that was missing racial and ethnic data, and that cases that are missing ethnicity, that's a huge percentage at the peak of the pandemic. In December and January, or the peak at that time, almost 40% of all of the cases that came back were missing data around ethnicity, compared to about 15% of cases. So that's almost 3 times as likely not to be a data element that was included. We saw hospitalizations generally stay below 10%, but at those times when there were spikes, that it became less likely to be collected. So what does this all mean? It means that we have a lot of work to do. And it means that we have to continue to focus on these relationships and focus on the data that are most important for communities to determine what is needed in the response. I did want to highlight one different area of data that we have related to the pandemic, and that is vaccination rates, where you can see here that those vaccination rates have actually risen relatively at the same rate, despite Maine's decision early in the pandemic to use an age-based tiering system. We did see that access to the vaccine was relatively at a population level. We didn't see huge disparities. That doesn't mean that there weren't disparities in particular communities and that there aren't still challenges with accessing the vaccine, but we saw a very different picture here with vaccination rates. Due to a lot of different factors, including who is most hesitant to receive vaccine, and also due to our ongoing partnership with community partners who approached the vaccine program right at the beginning. We had community partners involved right at this December line here. Community partners are involved at that stage. And so I think that helps to point a little bit of a picture of what's possible in Maine, given the size of our state, that when we work together, there are a lot of things possible. And I want to caution attributing this information to any one particular thing. And really that's with all of the data, that it's really easy to say like, well, this is what's going on and this is the reason. And the reality is that it's really different for each person that this data represents. And it's different for each community. And that's why we put a really strong emphasis on partnership with community leaders and partnership with directly impacted communities, because they can help to illuminate and make decisions about what is most important for them in a way that includes all of the things that are behind the data. So I'm going to stop sharing my slide for a minute and maybe ask if there are any questions about what I just shared. And then I can talk a little bit about what the Office of Population Health Equity, sort of where it's heading and what's going on our end. But I'll pause here because that was a lot of information and just see if you have any questions.
So folks could feel free to mute and or use the chat. I am seeing one in the chat in these data related to deaths, especially related to small numbers. Seems like small numbers cause great swings.
That's an interesting question. I think it's certainly something that could be at play. On the other hand, it's probably more related to the overall small number of deaths that Maine has had as a whole, more than it is related to there being a small number of people of color in Maine. And so maybe that's the way that I would answer it, is that we've had, fortunately, a much smaller, lower number of deaths compared to our overall population as a state. And that might make disparities within that overall small number a little bit more volatile, but it would not be related to the denominator there, the overall number of people of color in Maine, which is still a very large number. And so hopefully that helps answer the question. I'd caution that I'm not trying to be the only source of information on these data, and so we can also talk with our data and evaluation team here at DHHS to really look into this, since this is the first time that we've had some of these charts available.
Others, questions or? Okay, I'm not seeing anything else in the chat in, so.
Okay. Well, so great. I'm going to talk a little bit now about where we go from here at the Office of Population Health Equity. So as Liana mentioned, while this is a new name for the office, it's not an entirely new office. And so there's a lot of history that existed in Maine with the former Office of Minority Health and the staff and leadership of that office, and the work that they've done to get us to here. What I can say is that if we look at the sort of bigger picture, why do you have an Office of Population Health Equity? That's probably something that I'm more able to share answers with you about than like, what do you do with it? Which is something that we very much have to work in partnership with community to design the mission, vision, and strategic plan of the office. But what I can share is stuff that I'm guessing you've heard before, which is that the healthcare system and a lot of our systems are designed around the needs of the majority. And so at times this can produce useful advances in healthcare and health outcomes when you look at what is the most statistically significant intervention that's going to achieve the greatest good for the greatest number of people. That's not always a bad thing, but it can lead to disparities within specific communities that get lost when you look at this like population-wide number. This is like the problem. This is the intervention that's gonna address the problem. There can actually be pretty wide disparities there, even if you're just thinking about COVID. When you say that Maine was one of the least impacted states by cases, and that's typically a line that we hear, and it's true. There's not on the per capita case rate, Maine's doing really good. That ignores a disparity that was very real and very present among certain communities in Maine at different times of the community. So perhaps that's maybe a good example of why the office exists, is to help ensure that those disparities are illuminated as proactively as possible, because they can get lost when you look at population-wide numbers. So we really want to look at disaggregated data as much as possible to inform our decisions. And we want to ask questions like, what do we know? How do we know it? And what do our community partners know about it? And really thinking about where there's alignment on those things and when there's misalignment. We also want to think about questions like who is most affected by policy, programs, and systems. And so when I ask those questions, what we're really talking here about is primarily impact and not intent. We know that many of our policies, systems, and programs have an intent to support all people regardless of demographic characteristics. You might hear that as like an inequality argument. We're really focused here on what is the impact? What is the impact, and how is that impact realized and felt and perceived by the communities that we work with? And there we want to use an equity analysis to determine both how to fill gaps, or so what are the unintended consequences of our policy that require intervention, and also to think about how to prevent those gaps from happening in the first place. And so we will be in continuous dialogue with our community partners about these priorities. A lot of this information is not unknown just because I don't have a chart to show you about it. Our partners, I know we have a few on the call here, you know what the disparities are in your community. And so we want to work with you and with other communities to ensure that you have the information that you need to articulate what your priorities are, and that we can match our efforts with those priorities. And so with that, for both the community partners in the room and for other partners, health providers, we hope to serve as a thought partner on these issues. And we also encourage you to think about how you will go to your communities to seek this information, to seek this trust and relationships, and don't expect communities to come to you. So where we head as an office is looking at what are these interventions, what are these data-driven interventions that are going to advance health equity, and how do we illuminate what the disparities are on an ongoing basis so that people who are making decisions have that information informed by our community partners to determine what is going to happen next. We seek to ensure that our efforts are informed by and reflect the needs of the communities that we're seeking to serve, and to collaborate with leaders across the state and across our communities to achieve that purpose. And so that's kind of where we're heading. We have a pretty large opportunity ahead of us with a US CDC grant aimed at reducing disparities, both among racial and ethnic communities and rural communities over the coming years. And so we're excited to dig into this work to look at how we can avoid where we started in this pandemic, and build systems and resources and partnerships that are going to help avoid some of the things that you saw in the data. I would caution you that many of these things are caused by many things that are outside of the department's control, and they're all interconnected. And so there's a lot of work to do, but we're excited to do it in partnership with community and in partnership with all of you here today to achieve the ultimate goal of health equity, striving for the highest possible health for all people, giving special attention to those who are at the greatest risk of having lower health outcomes based on social conditions. And so I will pause again and see if there's any questions. I have a couple other things I can share about where we're heading with this Reducing Disparities grant, but want to make sure that this is most focused on the information that you're hoping to learn today. it's a bright and early morning, or it's not bright. I probably know where
It's not
anywhere
right
is,
now.
but it's early.
I might just ask, so same thing, folks, unmute or feel free to use the chat. I might just ask, actually either Liana or Ian, if you could just go back and explain. So I think, it's possible that people could hear Ian's role and say, well, what's Liana doing now? Just the relationship between your role, the commissioner's office, and this new office at Maine CDC. I don't know who's best to talk about that. But
I can
Liana's not going
start.
anywhere, number one.
That's probably important to have said. I was hoping that by introducing Ian, that was going to be obvious. But so my role, my title, for those who don't know, is Manager of Diversity, Equity, and Inclusion, and I'm actually located within the Commissioner's office here at DHHS. And so what my role is versus what it became for the last 2 years is probably slightly different from its original vision. And so I was hired to be much like an internal consultant on diversity, equity, and inclusion. So I should have a strong internal focus actually on our workforce, on our work culture here at DHHS, and really thinking about how we can begin to structurally embed greater systems, greater systemic value on equity throughout all of our offices and 2 psychiatric hospitals at the department. And so I work with senior leadership here at DHHS to really think about both how they can add an equity framework to all of their programs and policies, and really help think. So I'm policy focused as well as internally focused. Because we did not have the Office of Population Health Equity and headed into a pandemic 1 month into my time at the department, that's probably not what my job has actually looked like for the last 2 years, in part because, like many of my colleagues, we were doing lots of things that were probably outside of what we originally imagined ourselves doing. And so part of what I did in supporting the work around the development of the community of the contracts with community-based organizations, supporting the work of vaccine equity as well, will probably more appropriately live in Ian's world moving forward. So that those responsibilities will certainly shift, and Ian will then be able to take a similar position to what he has described on a number of health issues across the state. So hopefully that is helpful. We are still working through it. And I think the bottom line is we're going to work really closely together, right? I think I'm really invested in continuing to have relationships with community members and community organizations. I think it's important to drive our direction for diversity, equity, and inclusion, that it be focused on how it best serves the people of Maine. And so I don't intend to completely fade into an internal role that sort of disappears from connection to community, but really we'll work with Ian collaboratively to figure out how we are working to make sure that our roles are synergistic in that way.
Yeah, I appreciate that. So, what I guess I could say of maybe more of a look at like what's the difference between like this office and Liana's office. I think they are going to work very closely in partnership. I guess one of the things that is maybe most obvious when you think about like what happens at the leadership level is really looking at policy and systems, and the Office of Population Health Equity will certainly look at those things too, but maybe more of a program leading office. And so when you think about what are the responses to some of those things, and when you have programs that are going to be in partnership with community, that those are more likely things that would occur in the Office of Population Health Equity than in the Commissioner's office, particularly like programs and grants that are leading some of these interventions. But I think those are all going to be worked out in partnership with our community partners. And time will tell. I can say that this work is definitely bigger than 2 people, even within one department. And so we're excited to think about how to embed a lot of these questions in other offices. within DHHS and in your work, where all of you are. These questions are relevant at every organizational level. And so we hope to be able to illuminate with partners what some of the strategies are most necessary and most promising based on the vision and voice of people directly affected by those disparities. So I see a couple of questions in the chat. And so will or can I work with the state in how to best assess and address social determinants of health? Absolutely. I do not have a 5-step plan or a 10-step plan yet for that, but that is very much part of the vision for the Office of Population Health Equity. And when I talk about looking at root causes and trying to avoid having a bunch of responses that are always driven by the same social determinants, like we want to go after those social determinants first. And that's typically what we hear from our partners, is that we have to go to the root cause. We can't continue to design all of our interventions, even around COVID. All of the interventions that we have around COVID are related to root causes that have nothing to do with COVID. And so there's only so much that you can do with an intervention that's focused on one health outcome with what is really root cause community level concerns. What I will say is that will take a lot of work with our federal and state procurement processes that tend to focus interventions on exactly the opposite of what I just said, which is that you have a COVID program, you got to do COVID stuff with it. We have seen increasing flexibility. So with our COVID response programs, we've seen a lot more attention to social determinants of health and social care, social services than in previous federal responses. We've seen that in the Reducing Disparities grant. So I think there's a lot of movement there, but it will definitely take some work, because it's kind of a backwards design issue of like the how do you get there is very much all the other stuff that got us here today is still at play. And so there's a lot of work to do with our partners to figure out what are those paths that are going to be most successful and are most necessary. I saw a question here from Abby. Is there a specific area of health that the office may be focused on or would consider out of scope, like mental health? Dangerous to make any commitments this early. I'm on day 7, I think. I would say no, there isn't any area that's out of scope. That being said, the scope isn't determined, so there isn't anything out of scope is the best way to phrase it. And that we hope to have what we've heard from community partners through the COVID response is that intersectionality is really important. So looking at the intersections of multiple identities that lead to disparities, and also holistic approach to what health means to the communities that we work with. And so that's where we want to be, is at those levels of work, at the identities that are most relevant to the communities that we're working with, and with the definition of what health means and what strategies are going to achieve health that are defined by the communities that we work with. So if the communities that we work with say that mental health is out of scope, then it might be out of scope. I don't think that will be the case, but that's kind of where we're going, is really answering these questions with community partners. Another question here, will you be able to help the disability community to address the inequity and lack of providers in the state in dental care, mental health, psychologists? I would say same answer to that question of we would really want to work with directly impacted communities to determine what the root cause barriers are and what interventions you're seeing that are going to be most successful. I think, there are a number of different initiatives, and maybe Lisa or Liana might be able to share a little bit about some of the initiatives that are going on at DHHS around workforce in general. And I'd say, those are parallel track, but maybe not the exact same track as what we're talking about here. But same answer overall. And I'll maybe pause and see if there's anything that you can share about the workforce projects that are happening at the Commissioner's office.
I missed the question there, Ian. I'm sorry. So I just want to make sure I'm being responsive.
Lack of providers.
So it's that last one in the chat.
Yes.
Anything to address the inequity regarding the disability community's access to certain providers, particularly dental, mental health psychologists. So I don't know if you want to go ahead.
Yeah, I'm probably not the best person to answer that directly because I haven't been as directly involved as some of my other colleagues in the Commissioner's office around the workforce funding that's come through. And I know that's been a primary focus of some of that funding. And so I don't feel as prepared to talk about that today, but I would more generally say, with respect to this question and the previous one, there is a reason why the Office of Population Health Equity was designed at a director level and senior leadership at the CDC. And that is because we really want it to be a collaborative role across a number of our offices, both here in the Commissioner's office, but also with offices like the Office of Behavioral Health, the Office of Aging and Disability Services. Part of my role as I work with senior leadership across the department is really to think about how each of them can begin to embed the work of equity within this the scope of what they do, and then how those things can collaborate with one another across in a much more interdisciplinary way. And so I think we're at the beginning of this journey, but I also have seen a lot of increased focus from some of these other departments, both in the Office of Behavioral Health Strategic Planning, in ODE's Strategic Planning. This will not all be for Ian and Ian alone, as he said. This is not the work of one human to do, but we'll really work in conjunction with a number of other funding opportunities that have come to the state and a number of other strategic priorities laid out across our many offices. And so more to come. And it may behoove us to use some of the time from these, as we can talk about the way in which we communicate sort of moving forward, but it may behoove us to use some of the time either in these webinars or at another time to talk about those kinds of efforts as they develop, if that's of interest to this group.
Yeah, and I was just, go ahead.
Thank you. Sorry. Good morning. Congratulations, Ian. Thank you, Leanne. I wanted to sort of go through that thread of I do think I've lived in Maine for 21 years. When I came to Lewiston, we had 3 Somali families in Lewiston, and today we've got thousands and thousands of all backgrounds. And I just feel like we're talking about the same issues over and over and over. And the needle doesn't move as much as we would like to see. And I get it that it is, it's systems, and it's a very rigid thing to move any system. And so my hope is, I feel like with this office, we have a second chance to correct history and to do the right thing. And so I just want to caution that the communities that we're talking about, particularly my community, this whole concept isn't there. And that capacity and growth and knowledge and expertise isn't there. And so I do think that it starts with leadership. It starts with the leadership and really talking in a very candid way that, Ian and Liana and these people who are doing this very important work that's needed, that they are given what they need, the ability to move things, the need to work with communities, and the need to also have meaningful partnership with communities shouldn't be a checkbox. We've lived with that for a very long time. And so if we are intentionally saying we're going to make changes in people's lives, whether you live in rural Maine or you're a person who doesn't speak English, then we need to be honest about that. COVID has taught us a lot, and I feel like I'm hopeful that we have a foundation to work from, because that is with COVID, right? Because when we started COVID, things were not on the right trajectory. And we had to come in fully saying, no, this is not what's going to work for us. And so the idea of being dictated to be told what works for us and what's best for us, I think that's out of the window. And so I think we need a meaningful partnership, trust building, and correcting each other, and really developing this vision of equity, fairness, and meaningful impact. We want to see what we say in Augusta and what we decide in Augusta should have an impact on the individual who doesn't hear, who doesn't see, who doesn't speak English, who's elderly, whose sexual orientation is different. All of those things, the impact that you, the decision makers, have at leadership, we should be able to see it on the ground. And so I just wanted to sort of say that I'm very hopeful that this is going to work. Thank you.
Well, yeah, thank you. I really appreciate those. I really appreciate your perspective there. Certainly not the first time that I've heard it. And I think that's exactly right and really important for everybody here to hear that, you know, we do have an opportunity here in Maine, not just with this office, but with all of the work, all of the places that you work. Everybody that's here, you have this opportunity in time, and it's going to take us all moving together. It's not just the department's work. It's going to take systems, and so that includes more than just the department. And I think this type of work, this type of meaningful partnership is absolutely essential. So I really appreciate, I don't have anything to add. Your words capture my thoughts here, and I appreciate you sharing them. Lisa, I know I think we've got about 10 minutes left. So, you know, are there any maybe closing questions or thoughts that you have that would help us wrap up or begin to talk about, you know, what comes next for this group?
Yeah, well, again, thanks so much, Ian, for joining us and for sharing your thoughts. I did want to remind this group that we have been using a quarterly meeting schedule right now, and this is on the third Wednesday of the month, and so I think in December is after the 15th again, that same time. And we'd love to hear suggestions or thoughts for topics of focus. As you know, from having been on these in the past year, we have been largely COVID focused, and the goal is to be broader than that. So would happily take suggestions or requests for topics moving forward, speakers, panels, any thoughts that you might have. There's a question about how you get on the email list. Easiest way is to email me. So I'm going to put mine. I have the Outlook invite. We try to the word out as well through the professional associations, but to actually get the reminder, since it's quarterly and hard to remember, just email me and I will add you to the recurring invite for the webinars. It's asking for your email as well. Do you want to put that in, Ian? Unless somebody has the tricky middle initial, which most of us don't have, it's pretty much always first.last@maine.gov. So.
Well, I just want to thanks Lisa for the invitation to join you today. I'd say for this group, certainly not the last time that we'll be in touch, and looking forward to over the course of the fall, really working with you and with with our partners to articulate a vision and mission for the Office of Population Health Equity and figure out what some of the priorities that are most urgent here are. And we'll have a lot of different opportunities for engagement with those priorities, as well as different opportunities to carry out the work. I would say there's a lot of things that are going to be happening here as we figure out those priorities and as they relate to a number of different state and federal priorities that have really put equity at the center of a lot of our conversations about where we go from here and what it means to look, what the post-COVID, I don't know if those words will ever be actually together, but what is the infrastructure, what's the world that we're trying to create from here? Knowing that I think we can at least all agree that across the board, we're pretty equally dissatisfied, or maybe not equally dissatisfied, but across the board, folks are unsatisfied with the current state. And so, and where do we go from here is very much a question that we want to answer, and a question that we know that we will need your help to ensure that equity is at the center of that question. And that as Fatuma mentioned, that we have an opportunity here to do something different. And we will need all of your support with that in order to achieve the goals that we've heard shared.
Super, thank you. I'm just responding about the question about the recording of the webinar. So yes, we post them to the Maine CDC COVID website, and I'm going to post the link right now. You just have to scroll all the way down, and then you'll see a little icon, little placeholder for the slides, and then the Zoom recordings are right there as well. It typically takes a couple days, and actually I think my colleague at CDC is out this week, so it might not be till early next week before it gets posted, but they are there, and I believe you can get the past ones there as well. Okay, anything else? Great. All right. Well, thanks everybody for joining us. Thanks again, and welcome, Ian. And we're delighted to have you on board, and we'll look forward to any suggestions, thoughts, requests that people have for next time around in December 15th. We'll be at a different place. We will. All right. Thanks so much. Bye-bye.